I appreciate the time constraints, so I'll try to stick to them. Let's move on. चूँकि टाइम हमारे पास कम है तो इस साल मैंने कोशिश की कि I'll just put forward an 8-part plan how to analyze and manage pulmonary embolism ताकि हम सारों को practical approach पता लग जाए. पढ़ने को बुक्स में जर्नल्स में आपको बहुत कुछ मिल जाएगा. So let's see. So stats देखना क्यों ज़रूरी है हमारे लिए? Stats देखना इसलिए ज़रूरी है हमारे लिए कि if you just look at the stats, you will find the percentage of silent embolism occurring across different subsets of patients while admitted in the hospital. And you can appreciate in the last line the link of DVT with pulmonary embolism. So these are the patients जिनके लिए हमें ना कभी कॉल आती है ना हम कभी सोचते हैं कि इनको pulmonary embolism हो रहा है कि नहीं हो रहा है. But these are the published stats validated in studies that tell us that pulmonary embolism is a very much reality. So this was the paper published in 2007. These are the European study numbers, and it just refocused the light on pulmonary embolism. Just look at the mortality numbers and just look at how many patients the European scientists and doctors missed and they were diagnosed post-mortem. So just have this thing at the back of the mind, yet pulmonary embolism is a very much reality. Just a single slide to ascertain that pulmonary embolism, once the right ventricle gives way, it's all over. And the cascade, the spiraling cascade of death starts with right ventricle dilatation, of which we have raised pro-BNP as a surrogate marker. And it is all reversible till RV ischemia occurs, of which we have TROP-I as the surrogate marker. So once TROP-I is raised, it's almost the heart is going to give way and then it leads to death, no step in between. So it's an 8-part management plan. So the first step is that once you get a call to ascertain whether a patient has pulmonary embolism or not, you will have to analyze the pretest probability, and this is called Percy's criteria. Pulmonary embolism rule out criteria. This is an 8-point criteria. I'll show you in the next slide. All these questions can be just simply answered on the bedside. No test needs to be done. And if all the 8 of these answers are in the negative, then you need not do any test, for the risk of pulmonary embolism is just minimal, just less than 2%. So just remember these 8 simple questions. And if even one of them is positive or in the affirmative, you need to move to step 2, which is the rule-in criteria. These are the world-famous Wells criteria. And again, these are just a set of 7 questions which can be answered right on the bedside. No need for any test. And after analyzing these 7 points, you can have a probability stratification, either a 3-tiered one or a 2-tiered one, which will give you the risk of this person having pulmonary embolism, either as high, moderate, or low, or pulmonary embolism likely or unlikely. Some people prefer the old Geneva criteria, which have been revised. These are 9 points, again simple bedside questions. And in pregnancy, the years criteria have been validated and are in vogue, and these are just simple 3 points. These have only been validated in pregnancy and not in other settings. So if you get a call from gynecology, do think of these simple 3 criteria. However, these have to be coupled with a D-dimer test. And after doing a years criteria, you do a D-dimers test, and if the cutoff is more than 1,000, if the patient has 0 criteria, and if he has 1+ criteria, then the cutoff is 500, not 1,000. So these 2 steps tell you whether the patient has pulmonary embolism or not, whether you should proceed further with any testing or not. And after you want to proceed further, this is the algorithm that you rely on. If the patient has Percy, all criteria negative, the pulmonary embolism is ruled out. And if the Wells criteria is more than 4, or Geneva or years criteria, and the agreed D-dimer cutoff value is more, then you proceed with the test, which can be CT angiography or VQ scan, depending on what your hospital has. And if the patient lies in between, you can either rule them out or proceed further with the testing. Step 4 is assessment how severe your patient is ill. For this, I will like to point your attention to American Heart Association definition of massive pulmonary embolism, submassive pulmonary embolism, and non-massive or low-risk pulmonary embolism. Simply put, if the patient is not maintaining blood pressure for more than 15 minutes, he is suffering from massive pulmonary embolism and needs to be looked after immediately. And for submassive pulmonary embolism, either the RV dysfunction has to be there, or the myocardial necrosis is there, either the tropi or elevated pro-BNP, or you can have ECG or echocardiography at your disposal. For the submassive subset, three things need to be further clarified. How much RV dysfunction is there, how much is the comorbidities, and what is the shock index. These three things will guide you how much and how far you should go to help this patient immediately. After this step, the next step is that you have to assess the bleeding risk, because you are going to put the patient either on thrombolysis or on anticoagulation, and you need to be sure how much is the bleed risk. Again, a set of Hasblad criteria involving just 3 tests: renal function, liver function, and INR, and 5 questions. And after that, you can just have a quick look. These are the total scores, and based on that, 12.5% is if the score is maximum, is the risk of this patient bleeding, and you should avoid immediately and move on to some other strategy instead of anticoagulating this patient. Contraindications of anticoagulation, we all know: active bleeding, anything wrong north of the cervical spine, and severe thrombocytopenia less than 20,000, and some of the relative contraindications are shown as well. Moving on to the 6th step, where actual treatment occurs. So this is a simplified chart. If you have diagnosed pulmonary embolism, the patient is having high risk, you should immediately move to whatever form of therapy is available at your disposal. If the patient has low risk, you can either admit the patient and put him on anticoagulation, or you can send him home and giving him direct oral anticoagulation. And for the intermediate risk or the submassive, you need to admit, you need to monitor vital sign, you need to further stratify, and you need to keep an eye on him, because he will deteriorate 48 hours to 7 days after his first attack. All these things are available online. You can contact me, so no need to really look into it. If the patient has massive pulmonary embolism, thrombolysis is the key, and depending on bleeding risk, you can either employ systemic thrombolytic therapy, or if the bleed risk is high, you can have catheter-directed thrombolytic therapy if your institution has the capability. If not, embolectomy is generally the last treatment of resort. For it, ECMO support is required, which is restricted, I think, to 1 or 2 centers currently in Pakistan. So you just should know that this can be done. For the submassive patient, you need to direct therapy, again, based on the bleeding risk. If the risk is low, you need to put him on anticoagulation. And if the risk is high, or the anticoagulation is contraindicated, you can consider IVC filter in this patient. Door to needle time is the new buzzword in almost every disease, and so for pulmonary embolism as well. If empiric immediate anticoagulation is necessitated and the patient has low probability of pulmonary embolism, and your diagnostic study is expected to be delayed for more than 24 hours, you need to put this patient on anticoagulation. For intermediate probability, you can wait 4 hours. However, if the expected time for completion of your test is more than 4 hours, you again need to start him on some form of anticoagulation. And for high probability, obviously, you need immediate measures. These are the current recommendations in various studies. Just these 3 are now recommended: apixaban, rivaroxaban, and low molecular weight heparin as the initial form of therapy. And for long term means up to 3 months, and extended period is more than indefinite, from 3 months to indefinite period. So just these 3 are now recommended to start with if you want to start the patient on anticoagulation. These are the 5 classes of anticoagulation available to us. Unfractioned heparin is still the boss, still validated, still can be used in almost all settings. However, as we have newer drugs coming up, so the choice is yours, whatever you want. And this chart gives you the initial phase of anticoagulation. Remember, Epixa, Rivaroxa, and low molecular weight heparin are the only three initial phase drugs recommended. And dabigatran, edoxaban, and warfarin needs a run-in period of low molecular weight heparin before they can be reconstituted. They cannot be started straight away. Moving on to the duration. Duration is determined by how much is the risk factor for recurrence, and it is a sum total of patient-related permanent risk factors and setting-related temporary risk factors. In children, we believe that DVT is generally unprovoked, and its embolism is the base, so we have to tackle that. And this last point, please keep in mind that various studies have shown that thromboembolism actually increases the risk of subsequent MI. So it needs to be tackled right away. So these are some of the setting related or provoked risk factors. All these are available online, no need to focus, and these are all different settings that we have already seen. And these are a set of 11 deficiencies so far that we have been able to have a test and we can diagnose them. And obviously these are the unprovoked or inherited thrombophilia factors. And this slide gives you the actual duration of treatment based on the risk of recurrence. If the risk of recurrence is high, you can go from 3 months to indefinite period. Indefinite period is idiopathic setting, more than one, recurrent setting, and in malignancy, you need to have an indefinite anticoagulation. In all the others, especially if there is a major transient risk factor involved, just 3 months of treatment is sufficient. Some special circumstances, thrombophilia testing should not be done. Why? Only 30% of patients, even with a family history of first degree relative, will actually have positive thrombophilia screen. It does not alter your management plan. It does not identify all the inherited causes. We don't have tests so far. And if it is used, it has to be used. It should only be done after completion of the initial thought out period of anticoagulation, not before. And especially if there is a strong provoking factor, you should not do it. And if already there is an indication for lifelong treatment, again, it should not be done because it will not alter your management plan. Just few of the chronic complications that we need to be aware of: chronic thromboembolic pulmonary hypertension, chronic thromboembolic pulmonary disease without hypertension, and post-pulmonary embolism syndrome. This is like the long COVID, where the patient has too many fatigue and weakness, and none of the test is actually in keeping with his level of fatigue or weakness. Subsegmental pulmonary embolism generally should not be treated if there is no DVT, and that is the case validated in studies. The 7th step is the mortality prediction, for which we have a PESI score developed. It just gives you some numbers so that you should know what to counsel your patient, how serious he is, and how he should adhere to his treatment. For low risk patient, once you decide to discharge, you can involve Hestia criteria. All these are available online, and all these are very simple. The last step is the follow-up, and I leave you with this beautiful chart published in European Society of Cardiology in 2022, and it just gives some set of things to have a look at diagnosis in the first weeks, at 3 months, and in the long term. All these we have more or less talked about. It just gives you something to tick about. Some emerging treatments, none have been promising so far. Per concept is pulmonary embolism response team should be there to have a formalized, pre-planned, and hospital resource-based agenda at their hands, how to tackle with patients. Take-home messages are more or less clear, I guess. You only see what you look for, and simple Percy and Wells criteria and D-dimers can rule out pulmonary embolism in 99% cases. CTP is a good surrogate to pulmonary angiography, and low molecular weight heparin, direct oral anticoagulation, and obviously unfractioned heparin are still the boss. So I was just rushing through due to lack of time, and in case you have any more questions, please feel free to ask me or all these stars of pulmonology sitting in the front rows, it would do you good to have pick their brains. Thank you very much.
Thank you.